Mary very much, and thank you, Michael, for all that you've done to help cancer patients. I think this is a great undertaking and really appreciate what Ireland is doing. 1997 was a really bad year in my life. It was one of those years when you'd like to forget, but you really never possibly can. It was marked with increasing back pain and the professional embarrassment of missing my own diagnosis for 9 months. As Mary said, my wife has MS for over 30 years. She requires constant lifting, and every transfer that I would make in 1997 to help her hurt my back. I was sure that it was just muscle and ligament strain. I felt that I needed more exercise and better body mechanics. Treatment for my pain increasingly was stronger medicines, physical therapy, exercise, and I was even seeing patients while wearing a TENS unit. I was very stubborn. One night while doing sit-ups at home to try to strengthen my back, I felt a horrendous pain in my back, and it was caused by that. An MRI, of course, shows all that remains of T10 was just a mass of compressed bone fragments. And those of you who are physicians might remember from med school you were taught the most common pathologies will be the most common diagnosis. When you hear hoofbeats, think horses, not zebras. I clearly remembered that advice by my professors, and I was wrong. I let that ugly zebra grow in my back for 9 months, thinking it was just a common horse. An SPEP showed a rather dramatic IgG kappa spike, and my diagnosis of myeloma was very obvious. I felt bad for missing my own diagnosis, but I kept thinking that it just had to be something less common. I did a lateral spine halfway through my pain, didn't see anything abnormal, and it just convinced me that I just needed to do more exercising. I've never forgotten how I was lured into the wrong diagnosis. Many, many times in the last 19 years, I've explained to fellow patients how difficult it can be to actually make the diagnosis of myeloma. The symptoms are nonspecific and are caused by numerous common maladies. It was for that reason that I wrote this article for other myeloma patients. If you can't read the title, it's called A Zebra in Nebraska. So put yourselves back in 1997 and consider what your therapy would be for that big plasmacytoma. Both single and tandem autotransplants were suggested. My cord was at severe risk, and an orthopedist suggested a Harrington rod. Instead, I chose a tortoise shell brace and 4,400 rads of radiation. I reduced my medical practice but continued it for 3 more years to maintain my group health insurance. My odds of living a long life were dismal. I had a median life expectancy of just 3 years. If 100 patients were diagnosed with myeloma in 1997, 96 of us are dead and 4 of us are alive. I plan to die. To ease that burden, with my death, I purchased a cemetery plot, bought a headstone. That was and still is the stark reality of multiple myeloma. It remains an incurable, deadly cancer. If you look closely at that headstone, however, you'll see lots of bird droppings. I've been one of the few fortunate patients that have survived for 19 years. Time for just lots of bird poop to collect on that headstone. Despite my fortune to be alive, I have absolutely no reason to rest easily with myeloma. In 2000, it came back with a vengeance and at least 13 bone lesions. We had no proteasome inhibitors. We had no IMiDs. I began vincristine, adriamycin, dex, and eventually had an autologous transplant. The transplant bought me 5.5 years of CR until myeloma came back again in 2006. It was treated with local radiation, Revlimid and Dex, which put it back into CR again. In 2010, my IgG kappa clone returned with painful ribs. We locally irradiated one spot, and I began Velcade and Revlimid. Everyone in this room is aware that we have made huge gains against myeloma in the last few years. Thanks to the collective work of you research scientists, the 5-year survival reported at last year's 2015 ASCO meeting was 45%. I'm sure the numbers are even better. In fact, Dr. Lockhorst this morning, I was happy to see his estimate at 66%. Does that mean the glass is half full or half empty? It was sobering to think that despite all the progress we've made, less than half of patients diagnosed with myeloma will live 5 years. The therapeutic armamentarium for myeloma has greatly expanded in the last 12 years. As we move across the timeline of newly approved FDA treatments, you'll notice there's a dreadful emptiness between 1986 and 2003. That was my era. Autologous transplants were certainly extending PFS, but it wasn't until bortezomib was FDA approved in 2003 and lenalidomide in 2006 that we really had some effective drug therapies. Thalidomide was used for 8 or 9 years before it was officially FDA approved in 2006. We had 2 huge approvals with carfilzomib in 2012 and pomalidomide in 2013. In early 2015, the FDA approved the HDAC inhibitor panobinostat, and then came myeloma's November to remember. That's what we call it. In just 2 weeks, in November last year, the FDA approved daratumumab, elotuzumab, and ixazomib, 2 monoclonal antibodies and an oral proteasome inhibitor. We now have good, powerful, and effective therapies for myeloma with a large range of possible triplet and even quad combinations. The key concern now is how to get them to patients around the world and, of course, how to pay for them. As our treatments have continually improved, so has our ability to drive responses to lower and lower numbers of remaining myeloma cells. In 1997, the definition of CR was a reduction of M protein by over 75%. Then CR definition changed to complete elimination of abnormal immunoprotein. Then stringent CR became the goal. When we added, along with CR, we'd add a totally normal serum-free light chain analysis. Now our treatment goal is minimal residual disease negative. In nearly all myeloma clinical trials, going forward, we'll use this MRD negative as a primary or a secondary endpoint. This slide illustrates 2 points. The deeper that we can drive the response, the longer the remission lasts. Even when we get to that magical spot of 10 to the -6th, or 1 myeloma cancer cell in 1 million normal hematopoietic cells, evaluated by either next-gen flow or next-gen sequencing, myeloma still comes back. The resultant remissions are going to last longer, but most of those remissions will eventually end. When will we ever really get to the point of cure? Can we get it low enough that we can reliably say cure has happened? I think this slide summarizes in pictures what those of us with myeloma feel about our cancer. Every fish in this whole scene's nervous about the sharks. Likewise, there isn't a single day that I don't think about, write about, or counsel someone about myeloma. This is a transition slide to spend a few minutes considering how myeloma affects patients, how we think, how we interact, and how we consider our treatment options. And of course, how we're ever mindful of that shark that's in our bodies. Myeloma patients are voracious seekers of information. We realize our cancer will likely kill us, but we know that educating ourselves and making intelligent treatment decisions can improve our PFS intervals and even extend our OS. In that regard, we're constantly interacting around the world. My Twitter contacts are just as likely to be in Australia, UK, India, as they are to be in California or New Jersey. Facebook, internet, myeloma newsletters make everyone your next-door neighbor. We patients are just as excited at what you're accomplishing in Ireland as what we hear from Dana-Farber, Mayo Clinic, France, or Italy. We need all of your input, your facts, and your research results. To those of you who foster research, including nurses and CRAs, in your quiet, reflective moments, you should realize that you are heroes to us. Our lives depend on your work. The lifeblood of improving our chances to live with myeloma is education. There's two tremendous organizations in the U.S., the IMF and the MMRF. Locally, education comes in the form of active support groups. Every Sunday in our hometown paper, you can find this advertisement for the Central Nebraska Myeloma Support Group. And as Mary said, I've been running this group since 1999. Every single person from that era is dead, and all but two from the era of 2000 to 2010 are dead. And if you read my business card, it says we're all about education and advocacy. Here's a picture of our current group members. Look at them, look at their smiles. If you consider, you really can look at this picture and you can't tell who's the patient and who's the caregivers. Once a year, we have an evening social with potluck food. My offering last year was this cake with a big red X across myeloma. And thanks to the effective treatments we enjoy, you in research have made our lives longer and better. We sincerely thank you, and we're also strongly remind you that your work is not over. The title of my presentation is Myeloma, Still Much to be Done. While our cancer is still totally deadly, things have improved considerably. In fact, as a physician, I can't think of any other cancer except maybe melanoma in which we've had more progress in the last 10 years than we've made in myeloma. These two graphs illustrate that we are indeed living longer. Notice especially the big jump in survival from 2007 to 2008. And of course, that's now showing the effects of the IMiDs and the proteasome inhibitors on OS. Look closely at that exciting Kaplan-Meier curve on the right, and the line right up here is patients in the Dana-Farber determination trial. At 4 years, 84% are still alive. Compare that to 1970, the 4-year survival was about 20%. With the potential promise of longevity, those of us with myeloma are now allowed or forced to think about our long term. In 1997, I just wanted to live. I didn't think much about how my bone marrow would be functioning 19 years later. However, patients are living long enough to think about our quality of life. I don't want neuropathy, and I want to live with neutropenia and constant infections. As a patient, I would much rather take 3 oral capsules at home each month than go to an infusion center on 2 back-to-back days 6 times per month. That's 12 hours minimum infusion time. In other words, I'd much rather choose ixazomib for my proteasome inhibitor than carfilzomib. This slide illustrates how I could have personally made some better treatment decisions from 2000 to 2004. I began monthly pamidronate therapy in 1998 and made the change to more powerful zoledronic acid when FDA approved it in 2002. Even though it was standard therapy at the time, I really mentally questioned whether I should be getting that much bisphosphonate. In December 2004, I was brushing my teeth and I saw exposed left mandible. My ONJ lasted for 14 months until this spicule of bone broke off in my mouth one morning. The point I'm making with this slide is to be very careful and selective with all myeloma-related therapy. Myeloma is not a sprint, it's a marathon. Every treatment decision we make may impact another treatment decision later on. My renal status is marginal, and I suffered ONJ for those 14 long months. I should have looked at the whole picture and cut back on bisphosphonate therapy sooner than I did. I made a couple of comments during my presentation about drug costs and enormous burden for patients. Most of you probably know this, but for those who do not, in the U.S., the FDA is not allowed to even consider the cost of a drug when making its decision for approval or disapproval. It can only rule on a drug's safety and effectiveness. A company is allowed to charge anything it thinks the market will bear. We patients have a mixed feeling about this. The system gives huge incentives for research and motivates companies to take big risks for big rewards. It also results in every new cancer drug costing well over $100,000 a year. I don't understand all of Europe's regulatory mechanisms, but surely in the USA, some measure of drugs' value simply must be part of the equation, the same way that you do it in Europe. Something has to change. Sorry, that one didn't project right. Something has to change because our system is unsustainable. In 2014, every single new cancer drug approved by the FDA was priced at over $120,000 a year, well above the average household income of $52,000. And we now use the term financial toxicity and acknowledge that many people actually just stop taking their drug because they don't want to bankrupt their family. Oh, that's what I should have done. What can the U.S. legally do? How can we regulate the price of the new drugs? An important start is to make clinical trials smaller, leaner, and faster. In this regard, the FDA has done what they're allowed within their authority by devising 4 expedited pathways for drug approval: fast track, accelerated approval, priority review, and breakthrough therapy are all mechanisms to help get the drugs to us quicker. And the mechanisms were definitely helpful in getting daratumumab and elotuzumab to us last November. We need better trials. We need trials which are more focused on the needs of patients and not focused on answering a scientific question. Trials designed around an interesting theory might look great on paper, but if they don't work in practice, if patients don't accrue to them, they're a waste of time and money. Unfortunately, most cancer patients don't really have those commodities. Better trials will lead to faster accruals, leading to quicker results, and those results and findings then need to be rapidly published and disseminated. I want to remind you again of the title. Myeloma, still much needs to be done. Those with myeloma still die. Less than half of us live 5 years. We very badly need your help and your research efforts. Today, tomorrow, and every day in the USA, 80 people will be diagnosed with myeloma. Ireland's population is much smaller than America's, but the proportionate risk is the same. Each year in Ireland, approximately 220 new patients will be told they have myeloma. They'll be confused and terrified. They need your research. They are counting on you to help them. Myeloma is a sneaky, vile cancer. It presents with multiple genomic structures. Through our various treatment courses, it often undergoes clonal tides. These minor clones become dominant and eventually develop resistance to our best therapies. Cancer, and myeloma in particular, is tremendously challenging. I've learned from many experts that what we call myeloma is actually 7 distinct genomically defined diseases. Those same experts report that we're continually learning that we don't even know what we don't know. Despite my unusually long survival with myeloma, and despite the fact that life expectancy has doubled in the last 10 years, it's still quite likely that I will die of my cancer. One of the most important things we can do is to pool our research, pool our outcome data, and use technology to make our cancer treatment decisions. We have the technology, we just have to use it and to make laws which force vendors and medical software companies to allow intercompatibility of treatment outcome data. Cancer patients have total buy-in with sharing our data. We're in favor of AACR's Genie project and ASCO's CancerLink. I'm a member of CancerLink's Patient Advisory Committee, and I wrote this ASCO post article explaining big data to patients so they understand it. To summarize, I would remind you that patients are more than their cancer. Each one is a life into which a disease has intruded. Myeloma research has given me a much longer life than I ever expected when cancer exploded in me in 1997. And I would humbly remind you that everyone in this room is just one lab result, one abnormal x-ray, one biopsy from suddenly being ripped from your routine into the frightening role of cancer survivor. Being cancer-free is not the same thing as being free of cancer. It just never leaves you. We've made great progress against myeloma, but we can't rest yet. There's still much to be done. 3 years after my diagnosis and experience in my first relapse, I had an auto transplant in August of 2000. My granddaughter Ellie was a chubby, beautiful 6-month-old. Cancer research has allowed me to watch Ellie grow up into a lovely young lady. I never dreamed I would be so lucky to watch her grow. Now sweet Ellie's part of a big family of 14 grandchildren and 6 great-grandchildren. To those of you who do the cancer research, record trial data, and help cancer patients survive another day, I humbly say thank you. Thank you for my life.
So if Dr. Omel doesn't mind, I'm sure there are loads of questions. Is that okay?
Sure.
Can I start, Jim, by asking you, how can we best put cancer trials to patients in your views? Just teach us some of your experiences about, putting the new research, which may be randomized, for example, to a patient who might be considering whether to join a trial or not.
I think one of the main things, Mary, is to help patients learn that each one of them can contribute to research. Every one of them, if they allow themselves to be in a trial, their treatment experience increases the outcome and the knowledge for all of us. And I think patients are getting very much aware of that, especially in myeloma. And as Dr. Lockhorst mentioned this morning, good trials like the daratumumab trial fill quickly. Patients are aware of trials, and if we can help perhaps like 2-to-1 randomization or 3-to-1 randomization so they have a better chance of getting into the experimental arm, that helps patient motivation too.
So, Dr. O'Connor?
Jim, a very powerful talk, thanks very much. I was wondering your thoughts on how patients can better be involved in motivating advances in cancer. And what I'm mindful of is if we compare the advances across different forms of malignancies, such as breast, where, particularly in the US, advocacy sort of led the way. And did some pretty amazing things, like, for example, putting in grant funding for breast cancer into the Defense Department budget, which is insane, but such was the force of patient advocates that they'd no choice. Myeloma has clearly advanced because of the impact of people like you and other associations that haven't just sort of said that things are in a bad way, but actually tried to guide things. But there are a number of other malignancies where things still linger and aren't as far advanced as we might hope. Have you a few brief thoughts on how one turns the anger, fear, and frustration of a patient group into a positive force for action in that particular malignancy?
It's a good question. I think the requirement is a real champion, someone who has the knowledge to put foundations together, someone who has the impetus, the fear of their cancer to really lead efforts. And I'm thinking of Kathy Giusti, of course, with the MMRF, and Susie Novus with the IMF. It takes someone who really wants this and just has it deep inside them that it just becomes overpowering. One thing about myeloma is that we tend to die more slowly than, say, pancreatic cancer, and we have time to learn about our disease. So part of it is education, and certainly it takes someone who takes the time and effort to really work to help advocate and educate others. Thank you.
Are there any other questions? Just before we let Dr. Omel go, I'd just like to acknowledge the presence of his brother Gary, who's come with him from the States as well. So, and that shows the solidarity of families.